Reumatóloga pediatra de la Universidad Estatal Paulista, profesora de reumatología en la Escuela de Medicina de Botucatu del Estado de Sao Paulo. Un placer nuevamente tenerla acá con nosotros, doctora.
Thank you. Muchas gracias. Good morning, almost good afternoon. I'm very pleased and honored to be here with all of you and your kind invitation. And my topic will be, could you please upload this slide? It's not appearing here. Thank you. Thank you for the challenging talk. This is management of refractory childhood lupus. And many of you have talked already about many of the topics that are included in my talk. I have no disclosure. And to get started, I would like to emphasize that I will talk just about some manifestations. As you mentioned before, there are many manifestations in the lupus, and I will emphasize here the differences about childhood lupus and adult lupus. And there are differences in organ involvement, and that's the challenge of lupus. In children, you have more frequently renal presentation, neuropsychiatric presentation, and hematological, especially with cytopenias. Other manifestations, as you could see for the other talks, vasculitis, oral ulcers, fever, and there is some main difference from the adults. That is the pulmonary involvement, ANO, and photosensitivity that are far more frequent in the adult series. So the challenges of lupus management, and before talking about refractory, you have to speak about the current evidence of lupus management, is the sequential involvement of all those systems and the unpredictable disease course. And you cannot predict any time of flare, and that results in high morbidity and mortality, as you could see from the other talks. Not to mention that below 6 years of age, you have to be attentive to monogenic lupus. So this is a special group to consider. And the challenges were reviewed recently by someone from Clovis Grupo, Vitor Trindade. For the lupus treatment, you have to consider when for the age where this patient comes from. So the racial and ethnic background, socioeconomic status, cost of treatment, and the healthcare system as well. So the response of treatment will be based on this, besides the natural history of lupus. So used to compare the lupus as a chameleon, this lizard that changes the color. I know you have much of this. So it changes the color all the time. And in the Greek mythology, there is another monster, this Hydra. The Hydra have many heads. So we compare the treatment of the lupus, of the Hydra hairs. You cut one hair, the other appears. And there is just one head that is lethal. So we still don't have the lethal head of the lupus. So you have to cut the heads and see what comes the next. So the childhood onset, much difficult because you don't have controlled studies. And children indeed have more renal involvement, more nephritis. So for the recommendation and the guidelines for treatment, we go straight for the adult recommendations. And only recently, very recently, we have some recommendations for pediatric lupus. And although the same recommendations could be applied to children, you have to be in mind the negative effects of the glucocorticoids, a linear growth, and many other side effects. So the treatment should be guided to adult data, but you have to adapt our treatment. So for lupus nephritis and for treatment, you have to consider lupus nephritis and non-lupus nephritis patients. And first, we'll go first for the lupus nephritis. It's present in 60 to 80% of the cases. And you have studied in our group the presentation with early nephritis. And early nephritis result also in more complex cases, in more chronic development. And this renal involvement sometimes can be tricky because sometimes we may have chronic renal disease at presentation because many times the nephritis is silent. So this is another challenge. And for the recommendation of treatment, we have established the parameters of biopsy. They are the same that are used for adults, the International Society of Nephrology classification. You have to assess the chronic and active diseases. And you have to consider also the vascular lesions of antiphospholipid antibodies, because there is another tricky challenge that is the thrombotic microangiopathy. I know it will be discussed later by other colleagues. So if you get the renal biopsy, it's always recommended. Sometimes, as Jovan mentioned, we cannot have the renal biopsy. You have to start treatment. But the indication of the first renal biopsy is very early, and you have to be attentive to this. Because the renal biopsy will guide us for the treatment and the best evidence of this treatment. So the methodology, the recommendation of EULAR were evidence-based approach, but also with consensus of specialists. So the treatment is coming from our practice, what works and what doesn't work. So nowadays, we tend to use hydroxychloroquine for all. So this makes a difference in lupus nephritis. Regarding to access to immunosuppressive treatment, although the proof that mycophenolate is equivalent to cyclophosphamide, and because cyclophosphamide has many side effects, especially in children with long-standing disease, azathioprine is an alternative treatment, but it doesn't work for all. And some other treatments, like class 5 nephritis with proteinuric range, nephrotic range proteinuria, the recommendation of starting immunosuppressive with cyclophosphamide or mycophenolate, it depends on what's available in your region. So that's make tricky for low-resourced countries. So this is our reality. So the main clue, there is no recipe, but this main clue is to optimize glucocorticoids. So the principle and overall treatment, you have to choose the correct dose of glucocorticoids. Start early, high dose, and taper early. So it depends on the clinical situation and what you can do. So the science of treating lupus is to decide on the bedside, on the clinical side, what's the best doses. So there are many protocols, as you can see here, and these protocols were established by the literature, by consensus of specialists. Prednisone and prednisolone are required most of the time by most of the patients, and the doses are high. to control and to spare high-dose oral prednisone, we use the pulses. And the MP3, 3 pulses of methylprednisolone, 30 milligrams per kilogram. And adjunctive treatment with hydroxychloroquine and other all immunosuppressive. Have the guidelines and the routine monitoring is necessary. So there is evidence, and this reference is about investigations to be done every 3 months for treating lupus patients. But as you can see, this large panel, sometimes you cannot do all this every 3 months' time. Our health system doesn't support this. So I stressed here in blue what we regularly do in clinic for blood count, ESR, CRP, liver function tests, and urine. The patient has to enter the appointment with this test for deciding treatment the next time. As shown by our colleague in the first talk, the recommendation for renal lupus, they are step by step, and you have the basic and adjunctive therapy that you have to be attentive. So sun protection, vaccination, exercise, no smoking, control of weight, and the target for control, all the disease status of mild, moderate, or severe. We have to stick to some targets, and the targets are the disease activity counted, quantitatively counted by this SLEDAI. So the target is to reach low disease activity, to get the lower doses that's possible for glucocorticoids. This is the recommendation, more recent recommendation of the EULAR task force. So the target is this, and is different from the adults. We now recommend for children less than 75 milligrams for maintenance. We recommend 5 milligrams, and I will show in a few minutes. So other treatments. What else we have to treat lupus? The biologics, yes, we have. And recently we have approval of a new biologic for lupus, this anti-bliss or belimumab. There are other drugs that are with planned trial, a clinical trial like anifrolumab that started in pediatrics as well, but not yet. And other adjunctive treatments like intravenous immunoglobulin antiaggregation, hydroxychloroquine or mepacrine for skin manifestations, plasma exchange for rare lung bleeding, lung hemorrhage, and even the autologous stem cells transplant are described in the literature. But the challenge is the absence, complete absence of licensed medication, even for belimumab. It's licensed, but it's not authorized in every country. So if you have persistent activity, renal or extrarenal flare, despite this treatment, we consider it refractory. So it's a difficult definition in terms of what is really refractory. Because to say lupus is refractory, you have to optimize treatment. So this is another challenge. So I brought here just the only trial we have for lupus, pediatric lupus. It's the Pluto trial. It's belimumab. It's conducted by Hermine Brunner with a multi-center international study. And this study, it was included very few patients, so the power for proving efficacy, it's quite not such insurance. And the other point is that mild lupus or less nephritis was an inclusion criteria, so you cannot generalize which patient could receive belimumab in practice. So it was compared, indeed, it was compared for regulation purposes. You have to compare with placebo. And there is a higher proportion of patients that reach the primary efficacy endpoints. And it's shown a safe profile at these doses, 10 milligrams per kilo per day at 0 to 4 and every 4 weeks. So that's the trial, but the practice, we still have to wait a little bit. For other rare manifestation or severe manifestations, we have the neurolupus and hematologic flares. So there are recommendations, and for these recommendations, again, they are mostly based in adult recommendations and adult evidence. So the recommendation for neuroimaging was very well discussed by Giovanni before. Just remind you, because Giovanni and myself were fellows. So we were contemporary in the fellows at Gaslini. He was coming, and I was coming, he was leaving. So we live the same reality. Sometimes you don't have neuroimaging. You have to struggle to get neuroimaging, and you have to treat. I reinforce this message. So if you suspect, you have to treat. So pulse of methylprednisolone, high-dose cyclophosphamide. See if there is antiphospholipid and anticoagulate if needed. So these are the recommendation, and we follow the steps. And for hematological flares, also sometimes the most challenge in pediatrics is thrombocytopenia. You have lots of other cytopenias, but we don't care much about the cytopenias, but thrombocytopenia you have to use. It's the only condition. Sometimes you have to appeal to mycophenolate and to rituximab, the blockage of B cells. So for refractory hematological cases, especially for thrombocytopenia, based on the experience of idiopathic or thrombocytopenia, you use rituximab or rituximab and cyclophosphamide. There is a reference for Thomas Lehmann that combines cyclophosphamide with rituximab, even though this is very controversial. So I will speak about one tricky thing that in practice appears a lot for us. It's a challenge for treatment in pediatrics because it's very much more frequent than adult. And in this study, Nathalie Gormezano from the Clovis group compared adults and children with macrophage activation syndrome. And in our cases, there was a strong association with pancreatitis. So it's another rare manifestation whenever you have macrophage activation syndrome or suspicious of macrophage activation syndrome. By falling SR, low cytopenia, high ferritin levels, it's always advisable to do a bone marrow aspiration, but sometimes we cannot get this bone marrow aspiration, so we have to treat with high-dose methylprednisolone, cyclosporin, even immunoglobulin. This strong association with pancreatitis has prompted us to always investigate and follow and even treat the pancreatitis because the mortality in this condition is very high. And in this study, it was much more frequent, as you can see for the figures Nathalie Gormezano obtained. It was much more frequent in pediatrics. For non-pharmacological treatment, limit UV exposure, address vitamin D. In case of teenagers, oral contraception, avoid if you have antiphospholipid positive. Treat comorbidities, and I remind you of all the comorbidities besides those were already mentioned. I mentioned to you the zoster, that's very frequent in lupus patients. The psychological issues of adherence of treatment, and the physical activity intervention. So don't forget this every day in clinic. This is the message. And for cardiovascular risks, like in adults, we have indeed in pediatrics a high cardiovascular risk because the survival improved. Lupus nephritis has 9% of renal survival. So it was observed also in young persons that had childhood lupus, that it's a 6 to 9 times increase of stroke and myocardial infarction. So there is a trial about statins that they were not such convincing of changing of the course of cardiovascular or risk or atherosclerosis. So you have to optimize treatment. In this case, hydroxychloroquine improves indeed the lipid profile. So that's the reason we add it since the beginning. And you have to look at bone health because you have high rates of fractures and osteopenia. So you have to treat when we need. This is one of my last slides, is about the treat-to-target strategy. We engaged in this recent project with Eve Smith to establish by consensus methodology with pediatric lupus specialists, including patients and parents, that this target I showed you over the EULAR recommendation. They have to be a strong understanding by physicians and parents, and establish also the time to reach the target. So in old days, used to wait. Nowadays, in 3 to 6 months, you have to reevaluate this patient. This is an approach based on the tight control of diabetes, hypertension, and arthritis. You have to stick to this target, and you have to reach the target. Until you get low disease activity, that's the target. Remission is an ideal target, but not in practice. From the databases of many country-wise databases, we could not find patients that reach remission such often, but low disease activity. So the low disease activity, it's low SLEDAI, and it's defined as an optimized treatment. And this can make a difference, make an impact of health-related quality of life. And you have to maintain the target over the time to prevent relapses, because the flares and relapses, they are strongly related to disease damage. So the treatment should be escalated based on clinical features, and if the patient has only serology, we disregard serology and we stick to the clinical. These are very close to the adult recommendation. As I mentioned, one of the modifications, it was the doses of prednisone, because it was considered children could stay on lower dose of prednisone, and it is terrible. Transitional care is another issue, not a matter of Asian development, but a matter of communication and continuity of treatment with the adult care. So let's keep rolling. You have to contact the adult care team and see all the psychological issues, see adherence, look for schooling, mental health, and quality of life. So this is a pediatric job. You have to go to the adult clinic and talk to them. And you have to protocol this. You don't have a protocol for transition. Every physician is in charge to do this. I do it myself. You have to go to the adult clinic and say, I have this patient. This patient has these needs. This patient, I know for long, they are very attached to us. They want to keep in pediatrics until 25, and you cannot maintain them. So this patient has a difficult transition to go to college. They have the critical issues of adolescence in general. So you have, this is a mention, Clovis, always take to us, you have to have a different approach. And last, I acknowledge very much the Brazilian group that is part of this chameleon group of lupus under the leadership of Clovis. We owe very much to Clovis, to this knowledge that we get in lupus. And also other groups, or international groups that are working hard in lupus. This is the Printo group, and the more recently, the Global Task Force for Musculoskeletal Health, that's aiming at a global approach and access to drugs to everywhere, and we have to do patient advocacy. And I invite you to this page to join the Global Task Force. And I finish here. Thank you very much, and sorry for taking such much time.